Thank you very much, David, and it's great to be here today, and thank you to Nutricia for inviting me to participate. And I'm really pleased that Anita looked at what the demographic was here in terms of what backgrounds people come from, because I think with head and neck cancer, as I'm going to tell you shortly, people are living for longer due to the advances in treatment, but they're going to be living longer with the consequences of their treatment. And currently they're on 5-year pathways and surveillance, but after that they're going to come out, and with additional comorbidity, etc., I think there's going to be a lot more oncology patients in general in the community, and particular head and neck cancer patients. This is a quote from Rebecca Nunn's work, which I strongly advise you, whichever area you work in dysphagia, to make yourself familiar with. And I think this really sums up what people feel about the swallowing when they're having radiation treatment. It's bad during treatment, but what you don't know, it's going to get worse, a lot worse, before it gets any better. And certainly that's my experience and experience of colleagues I work with. That said, it's a really, really exciting time in the field of head and neck cancer at the moment. We've got minimally invasive surgery going on, the robotic surgery, etc., which is incredible stuff. People are now able to achieve things they wouldn't have been able to operate on in the past. New microvascular reconstruction techniques to surgically restore and maintain function in people who are having previously huge operations for their cancer. Of course, before, as Joe Murray mentioned, it was organ preservation. We now know that organ preservation is synonymous with functional preservation. And it was either radiotherapy or you had surgery. But now it's often a combination, a multimodal treatment people are receiving with adjuvant radiotherapy, and quite often with the organ preservation patients, I say quite often, but in a group of them, of course, coming through for salvage surgery afterwards in radiated tissue, which creates all sorts of issues. It's also really excited. You'll see in the news, there's been a lot from ASCO, the American Society of Clinical Oncology, over the weekend, with the targeted therapies now that are being delivered, personalized medicine to accompany these traditional interventions. But one of the things that we do need to know about, and as I've alluded to already, are the late effects. What is it that people are going to be living with as a consequence of these very advanced treatments? And also, what about our interventions of speech and language therapists and dietitians and nurses and doctors, and how we support people during their treatment? We need to understand a lot more about that. I started a PhD in 2009, and around that time, this paper came out by Lefebvre and Ang. And for many years, radiation oncologists have been reporting on, we saw people at 6 months after their treatment and X% had dysphagia. Therefore, this was a highly toxic treatment and what have you. And Lefebvre and Ang, they published a consensus paper and said, you know what, it's not about how people are surviving anymore. And that had been a major focus of radiation oncology and surgical literature. It was that shift to, do you know what? We now recognise that the organ preservation era has perhaps not yielded the benefits to patients that we hoped. So therefore, it's not just about survival, it's also about function, and speech and swallowing measures should be integral to anything that is recorded. And Jan Lewin from MD Anderson was involved in this work. And that really set the standard for clinical trials going forward. So why are dysphagia outcomes so important? Probably most importantly, and if you're interested in this, I wrote a paper with Tessa Goldsmith from Massachusetts General on the subject. We've got a changing demographic. Traditionally, people would think of a head and neck cancer patient as being a heavy drinker and smoker, a combination of the two in particular being very toxic. But of course, what we now realise that a lot of patients who are coming through have human papilloma, sexually transmitted related head and neck cancers. So that's the origin of the head and neck cancer. Through changing sexual practices over the years, and human papillomavirus, called oral sex, is now one of the biggest issues and is on the rise in head and neck cancer. So we have a lot of younger people coming through, men in their 40s, also females, but men in their 40s coming through the system they're not smokers, they're not heavy drinkers, and they're arriving and they're presenting with advanced disease because they don't have the swallowing problems that people used to have when they arrived with T4 large tumours. They're just watching TV or shaving and they notice they've got a lump in their neck. And actually what they do turn up with is a very small primary tumour principally in the tonsil or the base of tongue, but with significant nodal disease, which puts them into stage 3, stage 4, requiring chemoradiation. And also, it's really important because, as I said, we've got this fantastic range of new treatments to tailor and personalise things. And of course, as a result of that, people are living for longer, particularly the HPV patients who are responding very well to treatment, but they're living for longer with the consequences of their disease. And there's been some very high-profile people talking about HPV-related head and neck cancers. Michael Douglas, of course, has been very public about his head and neck cancer, and more recently, Bruce Dickinson, who went on the radio and said, "Look, guys, if you don't smoke and you don't drink, but you've got a lump in your neck, you've got to get to the doctors," because that's how he discovered that he had a tongue-based tumour. And he's been successfully treated and is back on tour, I believe. So that's all good news. But let's not forget, of course, we've got our other patients coming through. And while there's a lot of discussion about HPV-related head and neck cancer being on the rise, there's also head and neck cancer generally is on the rise. As I said, treatment-wise, we've got fantastic endoscopic head and neck surgery that's available, and one of the ones which is one of the hottest topics at the moment is talk about transoral robotic surgery. And colleague Kate Hutchison at MD Anderson did a systematic review published end of last year, which said, with promising initial results with this surgery, really not having to have big open surgery, very targeted surgery. But as I've found, and I'll talk to you about this in a moment around radiation literature, variety of outcome measures and limited use of instrumental and patient-reported outcome measures, which are actually critical to understanding the patient experience. As I said, it's not just about survival, it's what our patient is left with and their perception of what they're left with. And longitudinal studies are required, and the great thing is that those studies are now underway, both in the US and the benefits of surgery underway here as well. My specialist area was around radiation oncology, and I looked at intensity modulated radiotherapy and carried out a systematic review in 2010, which I updated with my colleague Vim Polleri from Newcastle in 2014. Talk about intensity modulated radiotherapy, the fact that previously you might have a block of radiation coming that way and one coming that way, and then everything in its path, including the cancer, was treated, but so was all the healthy tissue. That evolved into 3D conformal radiation, which is extensively studied by my colleague Dr. Joe Patterson, who we're going to be hearing from later. And then it evolved into IMRT, and IMRT allows the shaping of the radiation beams to minimize the radiation dose to healthy tissues while optimizing the treatment dose to the tumor target volume. And there's other names as well. You hear IMRT as being an overarching thing, but I just mentioned that image-guided radiotherapy and VMAT, volumetric modulated arc therapy, all of which are just very advanced forms of IMRT. But similarly to what Kate Hutchison found with the transoral robotic surgery, very promising initial results with this radiation therapy, but a variety of outcome measures used and limited use of instrumental assessment, limited longitudinal studies, and as people know, it's not just about what happens in the first 3 to 6 months. We need to understand much later what happens to these patients. And I'm pleased that studies are now going to 2 years and some to 5 years in the US. And one of the issues has been, well, do you know what, and I'm going to show you some slides on this, which muscle, what should we be avoiding? Because originally, this technique, IMRT, was my professor of radiation oncology, Chris Nutting, in the UK, ran the first randomized control trial to avoid the parotid glands, to try and preserve saliva and optimize saliva function after radiation, the biggest complaint of patients. And then Joe mentioned again Michigan, and Avram Eisbruch and colleagues at the University of Michigan have then applied that parotid sparing knowledge about how you can bend IMRT beams around parotid glands to protect them around the swallowing muscles. But that said, which muscles should we be avoiding? Which groups can we avoid? And as Chris Nutting and I have been often talk about is, we have to remember it's all well and good avoiding all these structures, but there's actually a tumour in there that needs treating as well. So for those of you who aren't familiar with IMRT, just to illustrate, this is a typical planning volume for planning target volume there to the laryngeal area, and here for the planning target volume 2 to the neck nodes. And up here, this is a 3D model. You can see the yellow colour washes the high dose area. And you see that's quite extensive, but when it's treated with here a 5-field IMRT plan, you can see there's significantly less radiation. And the take-home message from these two pictures is that this represents a 50% reduction in the radical radiation dose to the healthy tissue, so the high dose to the healthy tissue. And you can see how beautifully contoured that is, thus hopefully optimizing function. Avram Eisbruch did some of the early pioneering work in swallow sparing, and this is a very nice image from Peter Levendag's work from Rotterdam at the Erasmus Centre. And what they found in the original work by Eisbruch was the muscles that were particularly effective was the superior, middle, inferior constrictor muscles. Those are often implicated, particularly the studies have shown the superior and middle constrictor muscles. So the higher the radiation dose to